So thanks for the kind introduction. Obviously, as we've heard from the earlier speakers, the mitral valve is a complex structure and is an apparatus rather than a single plane. And essentially, there are several components, all of which may result in dysfunction. And although, as Colin mentioned, worldwide mitral stenosis is an important focus in the US and Western countries, MR is our primary focus. And mitral valve interventions, we have many, and CT can help certainly optimize many of these procedures. So we have mitral valvuloplasty, paravalvular leaks, MitraClip, TMVR, valve in valve, valve in ring, valve in MAC, other percutaneous approaches, as we've heard earlier. And with some of these, this is not something we're doing routinely, but certainly CT could optimize. So this is a case, a recent paper from Holland, and they were looking at how CT can help optimize a number of mitral procedures, including paravalvular leak closure. So with paravalvular leak closure, what we do know is your transeptal approach can help facilitate a very simple versus a very complex and prolonged procedure. And if you optimize this, then it can certainly help things. We can also consider fusion, just as people are already doing with the Philips Heart Navigator. We can also consider CT fusion. This is something we're working on, but yet is not yet prime time. This is a historical slide for MitraClip anatomy, identifying optimal and challenging anatomies, but we can look at all these measurements on CT, but one of the earlier speakers showed some of the other data from this paper, but they also looked at unsuitable anatomy, and these included perforation, severe or multiple leaflet indentations, or a posterior mitral valve leaflet length of less than 7 millimeters. So we can screen for all of these on CT, and we can also use 4D motion to identify the actual area of problem, and couple this with a transthoracic echo to assess patients comprehensively pre-op. With the transeptal, I found CT useful in understanding what we mean by optimizing the distance to the mitral annulus, and how this is much more complex than just coming up and down in the septum. The fossa is clearly delineated by CT, and we may also be looking at fusion imaging to optimize this and simplify this. Percutaneous annuloplasty devices are certainly many. We have to better understand how we can select such patients, but one of the things noted early on was the coronary sinus can have the circumflex artery track in between it and the mitral annulus in some patients, and this is important to exclude. This can be clearly noted in CT. So mitral valve in valve, valve in ring, this is images from Danny DeVere's registry. These are procedures that we're using CT routinely. You're often protected, the LVOT is protected by your mitral bioprosthetic frame if you're doing valve in valve, but that's not the case with valve in ring. So a lot of the concepts of LVOT obstruction are relevant to many of these new prosthesis in mitral position procedures. So in Danny DeVere's registry so far, we saw 8% LVOT obstruction, which was statistically more than in valve. And this can be preempted with CT and cases selected accordingly. So this is the concept of the neo-annulus, the neo-LVOT, and how the anterior mitral leaflet displacement can narrow the LVOT and cause potentially life-threatening LVOT obstruction. So we can assess this on the baseline CT. Importantly, you should assess it dynamically in a multi-phase CT. So although we know that the aortic annulus is most relevant to be assessed in around 20% of the cardiac cycle, we think so far that assessing neo-LVOT obstruction is best at around 40% later in systole. So these are the predisposing factors we know so far. Small LVOT diameter, the septal bulge, larger aortic mitral angle, device protrusion, flaring, device canting, or hyperdynamic systolic function. Many of these we can look at comprehensively with CT. So Colin mentioned Myra's study, which we're going to participate in. Currently, we've done 6 cases of valve in MAC off-label out with the study. As Colin mentioned, you can potentially treat LVOT obstruction with a number of approaches. Important to note that when you have LVOT obstruction, it can be acutely life-threatening. So in terms of the contingency planning, if you're thinking about something like alcohol septal ablation post, you may need to put the patient on pump to stabilize them. Also, with regard to putting a prosthesis in the aortic position, you have to remember that depending on the anatomy, the obstruction may occur considerably lower than the plane of the aortic annulus. So it may be necessary to put in a self-expanding platform and then subsequently a balloon expandable valve within that. So these are complexities that one has to think of in advance. I can say that we've done one case of alcohol septal ablation immediately before valve in MAC, and it was highly effective in preventing LVOT obstruction in a case that we thought to be at very high risk. So obviously the best treatment is prevention, and there are new software tools that can help us predict the actual neo-LVOT area. And in Myra's study, it was 8%, but that was without adequate CT planning, which she's currently doing in more detail. This is our first case that generated a lot of excitement. A young patient with end-stage renal failure, occluded SVC, and was in fact turned down for surgery by a very high-powered surgeon in Alfredo Trento. So this was truly an inoperable patient. You can see here severe mitral stenosis. Mean gradient is 19. We selected the case carefully, looking at the neo-LVOT, and we thought it was going to be good with a predicted neo-LVOT area of 2. And here you can see the final result with a good distance in the LVOT and excellent function of the prosthesis. Here you see 3D echo, and here you see the transesophageal echo Doppler with a very low mitral gradient. So with regard to TMVR, we have a number of different devices, as some of the prior speakers mentioned. Each of these will have nuances that will be relevant by CT, but I think CT will address all of these questions in some detail. How we are sizing the mitral annulus is also an issue of debate. There are a number of parameters we can measure, and all of these can be looked at in advance, but ultimately we have to decide in these studies how we're going to size. Some of the software we're using takes into account the saddle-shaped annulus and derives a kind of a 2-dimensional area from that 3-dimensional structure. But it may be that we can just look at things in a much more simplified fashion. This is just a simple cross-section. These are the kind of measurements being used in the CardioQ study with a very simple 2-chamber view looking at intercommissural distance, or at least a derivative of that, and also the height of the left atrium. So whether we need to have complexities is unclear. There's also the relevance of the landing zone, which again remains unclear, but it's something that we certainly should be looking at. Some studies have blatantly excluded patients that haven't been suitable in terms of a posterior shelf. Whether or not this is important, we still have to see. So in summary, with regard to CT imaging, the mitral valve is a complex structure anatomically. All of its components and its motion can be clearly delineated with CT. CT imaging has already shown itself to be valuable in the early stages of mitral valve intervention, but has considerably more potential. Thanks very much. Thank you.